Good. So now I would like to introduce my colleague, Piers, who we work together with UKCLL Forum, and Piers took over fairly recently NCRI chair. And we really need to know all the updates and anything hot what's happening in clinical trials. Thank you, Piers.
All right, thanks for that. Thanks for asking me to come and talk. I'm It's always tricky to know how to talk about clinical trials because you want it to be as relevant as possible for a general audience. But I'll give it a go, and I've seen what else has been done in the course. So I'm going to focus on two different things. I'm going to first of all, for the first half of the talk, about how we can optimize our current agents, because I still think you've learnt over the last 2 weeks a lot about the drugs we use today in CLL, but we're still really learning how to use those best. And there's some recent trial data which I think, even though we're not got licensed treatments to give them that way yet, it's worth knowing. Your patients may well ask you about that. And also where we're probably going with those things. And then the second half of talks just a little bit about other things coming through. So just to think about this, in CLL in 2024, I mean, I don't think there's any role for chemoimmunotherapy in frontline for CLL anymore, or early relapse settings. Not if you've got access to our current agents. Now, clearly, that's not necessarily going to be true everywhere in the world, but in UK practice, which is what I'm talking about really today, I don't see a role for chemoimmunotherapy having a prominent role anywhere, really. We also have to say that we're actually doing very well. Monotherapy or combination use of licensed drugs are achieving excellent progression-free survival rates, although clearly there's still improvement to make. I mean, it would be great to have a treatment which completely eradicated your any chance of the disease coming back. But I think in general, we could say that currently used licensed therapy are achieving PF rates in frontline of 80 to 90% at 4 years. And just to recap the agents we've got, licensed are in solid. I just mentioned pirtobrutinib there because it's so close to being licensed. And I will talk a little bit about sonrotoclax, which is a next generation or a new BCL2 inhibitor, and the antibodies that we use. But mainly we're interested in, and really, how can we optimize the use of these agents for CLL patients today? I think another thing to think about in clinical trials, and you may wonder why I'm dwelling on this, but and I'm just going to show you a slide about progression-free survival supplanting overall survival, and some old data just to show why we might have done that. But we're all very comfortable talking about progression-free survival in CLL as a sort of surrogate endpoint for overall survival, and overall survival is often, it takes so long to prove that it makes a trial very, very difficult to read out. And you will hear about measurable residual disease. We talk about it quite a bit. And can we use that? Or is it appropriate, or is it feasible, rather than perhaps using the more traditional progression-free survival, and I put overall survival? If we are achieving very good efficacy outcomes in CLL, should we now be thinking more about toxicity? I mean, I was fascinated to hear, and I agree, that cardiovascular toxicity is poorly picked up by the CTCAE criteria, and I think it's true. We worry about some of the side effects of our drugs. Everyone's very worried about ventricular arrhythmias on BTKI, but the CTCAE doesn't necessarily pick that up when you report, for instance, a sudden death on study. So that's an interesting one. But should we also be thinking about quality of life in general? Are we good at thinking about patient-reported outcomes? And then finally, there is a group of patients who we're not serving well with our current drugs. And are we doing well in picking them up early, or thinking about alternative approaches? And actually, I'm not going to talk about that much today, but should we be thinking more about early intervention trials, or just using completely different agents? I'll talk about the different agents. I wasn't particularly going to focus on early intervention. I just thought it would be worth us just going back a bit and thinking about progression-free survival in CLL. And this is a slide from the fludarabine versus chlorambucil versus FC trial, the LRF CLL4 study, published there in 2007. This is not something we would be thinking about today, but this study was an example of a study showing that progression-free survival was actually an endpoint which was achievable with a different combination of treatment. It gave a meaningful readout, even though in this study, for example, overall survival at 5 years wasn't looking any different between those agents. But we were able to, and it was things like these trials, these early combination chemo trials, which moved on to progression-free survival being a valid endpoint in clinical trials. So just to go quickly to the measurable residual disease point, or MRD, this is something we talk about, but it's not relevant for all of our agents today, which is intriguing because it became quite relevant with chemoimmunotherapy combinations, but with BTKI monotherapy, measurable residual disease is not a very useful outcome, but more useful with venetoclax and certainly combination regimes, where we're now talking about it quite a lot. And just to say, we do this by flow cytometry in the UK. We've pioneered doing that nationally through the FLAIR study, for example. But there are obviously other ways of doing it, and there's increasing interest in looking at molecular assays, sequencing assays, next generation sequencing, even cell-free DNA and things. But just to say that when I mention MRD later, we're basically talking about a flow cytometry assessment. Here, a picture using 8 parameters and some definitions that we talk about. We talk about different levels of MRD. We talk about it in both the blood and in the bone marrow. And when we talk about 10 times 10 to the minus 4, that's 1 in 100. So 20 CLL events in 200,000 total cells. And there are different depths, and flow cytometry is good at picking up MRD4 down to 5. It is not good at 6, and we don't report out at 5, but it will pick that up. But the number of cells you need for that is a lot, and really to go to deeper levels of that, you're going to have to look at molecular techniques. So looking here, how are we giving treatments today? We're giving treatments continuously, and this applies both in the de novo, in the treatment naive group, and in the relapse setting. And we're generally doing that with single agent BTKI therapy. You can give it with venetoclax, but it is licensed, but it's not something we do that much. And that's something we tend to do down the line. And just to say that if we're talking about endpoints, we can talk about progression-free survival and overall survival with that. But MRD is not to date really proved a useful endpoint for BTKI monotherapy at all, because it's actually rarely achieved, and actually probably is not a meaningful outcome for us to look at. We're looking at planned fixed duration therapies, and these have mainly been the venetoclax treatments paired with monoclonal antibodies, or more recently with BTK inhibitors. And generally with these treatments, in most of the studies that we talk about, the treatment stops whether the patient achieves an MRD negative status or not. And I'm really thinking about, for example, the venetoclax obinutuzumab regime, or the venetoclax rituximab regime, or indeed the way that venetoclax is licensed with ibrutinib in combination, the VI regime, that stops at 15 months. And we don't really care whether the patient's achieved MRD negativity in terms of the treatment length, because that's the way it's funded. We might care for the patient, but we don't care in terms of whether we stop the treatment or not. And then finally, and I'm going to dwell on this a little bit later because I think it's so such an important result, and it's something that we've really pioneered in the UK. We have the MRD-directed therapy, and and this has mainly been done with the BTKI and ibrutinib doublet combination. It's done in anything else. And I just show there the scheduling that how we might give that therapy. You give it for a period, you measure MRD a lot, and then you decide whether you're going to stop it or not. And I'll explain the way we did it in FLAIR with some different slides. Other trials have looked at achieving MRD negativity and then just stopping at the point that's achieved. But it's a more complex way of giving treatment. And I brought all these things up because I think there are valid questions to ask about all of these treatments and how we give them. And I give you some examples of the way we're doing that. So continuous therapy, continuous monotherapies. I know that we were updated with the BTKI monotherapy studies and the recent ASH update of the ibrutinib versus the zanubrutinib. Nick would have talked about last week. We know it's highly effective. I show on the right there the data from the first readout we had from the FLAIR study, which is ibrutinib compared to, in fact, ibrutinib in combination with rituximab, compared to FCR chemoimmunotherapy. That was one of many readouts that we've seen of effectively BTKI monotherapy studies. And that was a big readout that we had in our study group. It's interesting, though, that we talk about continuous therapy. We say that patients are going to be put on the therapy until intolerance or progression. But actually, when you actually look at the data, many patients are off treatment after a number of years. And I'm really talking about 4 or 5 years here, perhaps. Now, many of those are due to disease progression, but actually you often find that it's due to intolerance. And not only that, you find that those patients who stop for toxicity don't necessarily go on treatment again. And actually, you find that those patients don't necessarily need future treatment. And we've obviously got quite a lot of concerns as we were thinking about in the discussion about BTKIs and arrhythmias, but I think we're all more and more apprehensive about unnecessarily keeping patients on treatment if they don't need it. I mean, why would you continue at treatment if you're not getting any real therapeutic benefit and all you're doing is causing side effects? And that's a piece of advice I give to all my patients who come to clinic, is I don't want to give you something which is going to cause side effects with no benefit. So I think a big study that we've got up and running now and is increasing is the static study. So this is going to happen in most FLAIR centers, I believe. We're hoping there were 101 centers in FLAIR, so whether we get 100 centers open for static, but we're asking the question is, can we safely discontinue ibrutinib therapy in the first instance? This study will be widened out to acalabrutinib and maybe other long-term therapies, and the strategy is to randomize people to whether they can stop treatment or not, and with the good opportunity that they can restart treatment should their disease progress. And that's opening up, and it's going to take quite a long time to recruit and get a good readout from that. But I think it will be a good study. Will actually answer that question, which I think may be happening de facto in the clinic anyway. But patients are now stopping BTKI, but we don't really know systematically about the outcomes of those patients. And I think this study will hopefully answer that question. So I think that's a very important continuous therapy or stopping continuous therapy trial that we've got going. Moving on to planned fixed duration therapy. I think it's fair to say that we've got, and I'm just putting here in the front line setting here, 2 established regimes. Clearly, we've got fixed duration therapy in the relapse setting as well. But thinking about frontline therapy, we have venetoclax with obinutuzumab, stops after 12 months, been proven in trials for both younger and for older patients that it's a highly effective treatment, although patients do inevitably relapse. I think on the whole, I mean, obviously long-term follow-up may find a group of patients who are not going to relapse, but at the moment we still think that most patients will relapse. It's got some issues. It requires quite intensive monitoring to start with a TLS mitigation, and you can get infusion reactions. But it's a very effective treatment, and it's a definite standard of care, and it's licensed both by FDA and EMA. And we've also now got the ibrutinib venetoclax fixed duration 15-month therapy. And that was the Captivate study, showed that in the younger, which is a phase 2 study, and the GLOW study, which was randomized against chlorambucil or obinutuzumab in the older patients. I think an important observation to make that, but I don't know if it is such a global standard of care. This is not licensed by FDA. So although EMA and the MHRA have licenses adopted this therapy, actually it's not been licensed by the FDA. It is clearly highly effective. You would have seen that data, but I think we do have some concerns about toxicity with older patients. And maybe in the younger patients, I certainly wonder whether the 15 months is sufficient for those with higher risk genomics, particularly the P53. But actually, when you look at the data, patients with 11q disease and unmutated IGHV are also beginning to relapse. And so it probably isn't an optimal therapy if you want a once-only treatment. So I think there is a role for a head-to-head comparison, an opportunity to test second-generation agents in both classes of these drugs. So I'm just going to mention this drug sonrotoclax, which is being developed by BeiGene. It's a newer BCL2 inhibitor. It's more potent than venetoclax, and it's got better activity, for example, against the one of the mutations which confers resistance to venetoclax with G101V. It's got a very short half-life, and BeiGene say that means that the risk of TLS is less. There is actually a 101 study using a combination of sonrotoclax and zanubrutinib. This is a dose finding and a dose escalation study. It's a 101 study. It's been trialed in many, many diseases. It's mainly taken place in Australia. But it is a global study. It is opening in a few centres in the UK, but I think they're now, I've just received an email to actually suggest it's going to be restricted only to tumour naive CLL and SLL as far as CLL is concerned at the moment. But there are some other cohorts, relapsed refractory mantle cell lymphoma. Anyway, there was some data at ASH which looked at this combination, and it seems to have a very favourable side effect profile. There weren't any real major concerns, nothing unexpected. There seems to be an instance of neutropenia, which if anyone's used a combination of ibrutinib and venetoclax, you definitely see neutropenia. That seemed to be the major grade 3 side effect that was identified. Other than that, everything is listed there as grade 1. And they show this extremely impressive Kaplan-Meier plot. But before everyone gets too excited, it is a very short median follow-up. It's only 9.7 months. But there are 100 patients in this study, and so far they're saying no one has progressed. Now, clearly, with this data needs to mature, but it's certainly looking like an interesting combination. So I think to let you know that the Celestial study is going to open globally, but it's going to have quite a good UK footprint. There are going to be 16 centres in the UK that are going to have this study open, and that will be directly comparing venetoclax obinutuzumab, that's in the blue, to this new combination, which is going to be zanubrutinib and sonrotoclax. Now, this is going to be given as a fixed duration therapy, so it's going to very much mimic the Captivate and GLOW regime. So we're talking about a 15-month fixed duration therapy here. And whilst things like MRD and obviously other genomics and things like that are going to be monitored, there's going to be no treatment given on the extended treatment given on the basis of MRD. But that will be opening very shortly and will be available. I'm just going to dwell a little bit on MRD-directed therapy. I know, I think Helen mentioned the FLAIR study a little bit, but I do think it's worth being aware of what we've done in the UK, simply because I think the results are fairly remarkable. And I think it's very possible that patients will come to clinic and ask you about this treatment. And I think it's something that we need to continue to push on the need for. And I think there's some more work to be done here. So this was presented at ASH and was also recently published. And I just want to go through the principles of the study, or what we were trying to achieve in terms of the endpoints. And these are figures that Pete Hillman has often presented over the years, but he preceded his presentation on FLAIR with this study, showing this modeling of MRD and just showing various lines here. So your CLL disease bulk is on the left axis here, and then over time. And the argument goes, if you give a treatment that you decrease your bulk of disease, and you might not actually even achieve an MRD negative remission, but if you stopped treatment, let's say here, when let's say at 1 year, that your disease will begin to bounce back. So, but there might be patients who you do indeed achieve MRD negativity on this green line, and I'm looking at the lowest point of the curve. So let's say you give treatment for a fixed duration, and this was originally concept would have been with something like an FCR regime, and you stop at 9 months. You get MRD negativity, but inevitably the disease is going to come back. But ultimately, with patients, you might actually be able to completely eradicate disease, either no detectable disease at all, or such, and that would be a potential cure. So the philosophy behind the study was that actually no patient is going to respond necessarily to a treatment in the same way. So you give a treatment in some patients, so the red line, you're going to get a very fast response, and you might hit that potential cure threshold at 2 years, for example. Whereas the green line, those patients who've got less sensitive disease, yes, you're getting MRD negativity at 2 years, but actually they've still got quite a bulk of disease, and the blue patients aren't really responding at all. And the philosophy behind the study was essentially you would reach a threshold of MRD negativity, and this was actually bone marrow negativity assessed from 12 months onwards, and you'd give the same amount of treatment again. And this was modeled on breast cancer dynamics and something. And these were the results, and they are extraordinarily impressive. This is a progression-free survival for ibrutinib venetoclax given in this MRD-directed fashion, and you're getting progression-free survival of 97% at 3 years. I don't think there's any phase 3 data out there which has such impressive results in such a large cohort of patients. And we're talking about here a study of 500 patients. So this is completely unprecedented. It seemed to be particularly good, and I'm just giving you some examples for certain subgroups, and I give the example of 11q disease here. 11q disease is always thought to be a poor prognostic factor. It improved with rituximab with FC combination. And I just put here on the left, if you in the original arm of the FLAIR study, just giving ibrutinib, you got a good response actually. But with ibrutinib venetoclax given in an MRD-directed fashion, you just get this amazing flat line. Now, clearly this is still early days, but this is a very impressive data. And I just put there that if you give it in the Captivate regime here on the left, where you stop it, interestingly, those patients, and that's the yellow line here, are beginning to progress. Whereas we're just not at the moment seeing it with the MRD negative patients. So for some patients, this seems to be amazingly good. And I think the answer is we need to think about what we're going to do with this. Ibrutinib venetoclax is not licensed in an MRD directed fashion, and it's not funded that way. And I think we need to, as a community, to think about how we're going to take results like this forward and think, are there subsets of patients who might want it? Is there a need for it? And I think there probably is. We also need to make sure that our commercial partners are interested and that this is something they want to do. And I think one of the problems with a study like this is with such amazingly good PFS that it's going to be difficult to get a readout, which is going to be meaningful for a study to be done. So that's something to think about. I think we need to persuade our global colleagues that MRD-directed therapy is something we should do. And that's interesting that it's not been universally thought to be a good idea. And a lot of people I spoke to, for instance, at ASH, didn't think this was something we would be adopted generally. The Germans, though, will adopt it in one of their newer studies. And I also think we need to check that our patients are keen on a slightly more complicated way of giving treatment. And maybe we can discuss this in the discussion about, is this something we really want to do? Or would it actually be easier to present patients with extremely good treatments anyway, and as giving it in perhaps in a slightly simpler fashion, and then we can watch them in the traditional way we did. So I'm now going to change tack and think about what newer agents might be coming onto the field in CLL for those group of patients who we're not managing to do the best with our current combinations. So there's no doubt that BTK remains a major target in CLL. It's highly effective kinase to target. We saw that with ibrutinib. We've seen that with acalabrutinib and zanubrutinib, and I'm sure you're all aware of the later data with the non-covalent ones, but they're still mainly in trial. Just put this diagram up just because we all talk about BTK being linked to BCR receptor signaling, but it's just possible that, well, it's not just possible, it's definitely true, but actually BTK is also targeted by other pathways, and it's not just about BCR signaling that taking out BTKI or inhibiting BTKI is good news. And that probably has the roles in adhesion and migration, why we see the lymphocytosis when we give a BTK inhibitor. It's also got a scaffold function, and that's becoming a little bit clearer. And that's becoming clearer both from having used these non-covalent BTKIs, but also with the degraders, which I'll mention in a moment. And so we have the covalent BTKIs, and that is ibrutinib, acalabrutinib, zanubrutinib. All of them bind the same in the same place on the kinase and inhibit BTK in the same way, whereas the non-covalent, the covalent BTKIs are inhibiting the kinase directly. That's the right-hand diagram, whereas the non-covalent BTKIs are actually inhibiting the kinase function of BTK in a different way, and in fact, they appear to keep it in a more closed formation. And I'm sure you are aware, and just to mention that there are these non-covalent continue to be trial, and there's data, a lot of data now using pirtobrutinib, and this is the LOXO compound, and here's just an example of the most latest data from the Bruin phase 1/2 study. I think that this was shown by Nick again, showing highly effective for those patients who've got resistance to the covalent BTKIs. But to let you know that there are ongoing studies looking at pirtobrutinib plus venetoclax, for example, and rituximab in previously treated patients. So that's looking in a relapse setting. That's a study that's open in centres in the UK. And then this nemtabrutinib compound, the MK1026, their studies currently open, looking at in a phase 2 setting, just the variety of hematological malignancies, and there are going to be phase 3 studies opening. They've just been approved, and I think the one which has been mainly adopted in the UK is the one which combines it with venetoclax as a combination, so nemtabrutinib, venetoclax versus venetoclax rituximab in the relapse setting. So again, that's a study that's open. What I've tried to do is in these slides is just highlight studies that I'm aware of that are open in the UK or about to open in the UK. So I think there is a role for the non-covalent BTKIs, and there are ongoing trials looking at that. These are very interesting compounds. These are the PROTACs, the proteolyzing, and people have heard of the BTK degraders. And I guess the way of thinking about these is they are a way of linking the molecule of interest. So for us, it's BTKI with the PROTAC, which is the sort of glue. And this then can bind, can bring the in this case, BTKI to a system of interest. So with the degraders, we're talking about the ubiquitin pathway. So this picture is meant to illustrate this, that you can add BTKI with the PROTAC in the middle, and it binds to E3 ligase, and that causes ubiquitination of protein. That goes through the proteasome, and it degrades the BTK. Now, some of these compounds are also being bound to the cerebron complex, which is actually also the way the lenalidomide works. But if we think about them, they're degrading BTK protein. And just to show what the difference between a PROTAC might be on the left compared to a kinase inhibitor, this complex, so it's sort of a bit like a bispecific, except of course it's not an antibody, but it's bringing BTKs together with the E3 ligase, and it's binding the outside of the of BTK, whereas a kinase inhibitor has to be very specific and it inhibits the enzymatic activity of BTKI. And there's different binding qualities. You don't need the active protein, the kinase, for the degrader to work. And both the enzymatic and non-enzymatic functions are removed with the degraders, which the inhibitors only inhibit the kinase activity. Now that's I'm just showing you all this because people tend to throw these things around. They start talking about scaffold functions of BTK and things like that. And I'm just trying to take through some of the chemistry so you understand that. And just to say, there's data now out of the Nurix compounds. There are 2 compounds. There's something called NX2127, which also has this additional cereblon and Icarase degradation activity. And then there's one which is in the UK, which is the Nurix 5958, which is a BTK degrader only. It's all very early data, but everyone's very excited about it. In the American study, which is the 2127, here's a swimmer's plot showing the responses. And although I don't think the projection is that brilliant because these are from the ASH conference, there are some of the responses are looking very good, and patients remain on treatment with minimal side effects actually. Very early day with a 5958, but 3 PRs, three stable diseases, and on the patients on studies, this was reasonably good, and they seem to be manageable. So BTK degraders seem to be the latest kid on the block, and so we've got the Nurix one already open. BeiGene have got a compound, so there's going to be a phase 1 study of that, and there's also going to be an AbbVie one as well. And these are all looking at CLL in the relapsed refractory setting at the moment. They're also looking at other malignancies. People are particularly interested in looking at activated B-cell type lymphoma and other lymphomas such as mantle cell lymphoma. But as far as CLL goes, it is looking in the double refractory kind of space. Loads of other small molecule targets, and there'll be various compounds around, and I just put this picture up here as an example of other areas people looking at MALT inhibitors. There are going to be new BCL2 inhibitors, as I've already mentioned, and other targets of the venetoclax pathway. But I think it's also these other cells around the CLL cell, which is what we're interested in. And I think it's fair to say that CLL is a bit behind the curve when it comes to bispecifics. I think they've made great dynamic strides forwards in high-grade lymphoma, in follicular, in mantle cell lymphoma, but actually there was really no data on bispecifics in CLL. There's a little bit of data on Richter's. I'm not really covering Richter's today, but there is now some data on epcoritamab, which, as we know, has just been funded for other indications, licensed and funded for other indications. So we're going to all become more familiar with using epcoritamab in high-grade lymphoma. But this is some data from a small cohort of multiply resistant CLL patients, which was actually presented at the IWCLL. And this is a subset of the EPCOR-1 study. For those who know, there's actually some quite interesting data of epcoritamab in Richter's syndrome, suggesting quite good efficacy as well. There was some data presented at ASH of this compound, which is MVG111, which is a ROR1 CD3 bispecific humanized T-cell engager in this case, and this was presented by Parag Jasani, showing that there were some responses in this cohort of patients, which included both CLL and MCL, and I believe that the plan is to have a follow-on study for a bigger cohort of patients with CLL. So, so the EPCOR CLL1 study is open at, I think, at least one centre in the UK. there is a study of mosunetuzumab, which is also, I think it's just one, which I'm not sure about the top one, how many centres it is. It's quite difficult to find this information out, but the Mosun study is definitely one centre in the UK, and the MVG one's actually open in 6 centres, although it's not currently recruiting to CLL. What about CAR T? And people who've heard me speak before know that CAR T started in CLL, but then it sort of fell up, sort of slightly withdrew its prominence as it became more important in the ALL field and in the high-grade lymphoma field. But there was this very interesting report in Nature 2022 indicating that some of the very first patients treated with CAR T were indeed patients who received T-Gen, and they've still got circulating CAR T and they're still in remission. So there is some data now with liso-cel, and this is updated regularly. And again, I think this was mentioned last week by Helen when she was talking about refractory disease. And this is a phase 2 study, and this was the latest update at ASH 2023. And these are really very similar curves to what we've seen before in terms of, I think it's just got a few more months added onto it. But what we see is that the cohort who respond really well to liso-cel, and these are difficult to treat patients, are getting very nice durable responses if they achieve a CR. The black line is the whole population. So on the left, we've got the full study, and here we have patients who previously received progressed on BTK and venetoclax. The large group of patients, though, here are the non-responders, and they aren't doing very well. And I just think we need to continue looking at this data. Clearly, it works for some patients, but I don't think we've really identified which ones it is. It's a bit late to learn afterwards that they've achieved a CR. We really want to know that before we give it. But just to say, there's going to be a phase 3 study, which is going to open shortly. It is open already in the US, but it's going to open in the UK at a number of centres. I think it's going to be 4 centres in the UK. And this is going to be a phase 3 comparing liso-cel to investigator's choice. And people who look at the investigator's choice on this call might be interested to see it's idelalisib or bendamustine rituximab. But I think the nice thing about this study is there's a crossover. So patients will potentially, if they fail one of either idelalisib or bendamustine, they will get liso-cel. There's also the obe-cel compound, which the at UCLH, and this was the data from ASH, suggesting that they did get some responses in their CLL cohort. They seem to have treated 8 patients. We don't have any data on 4 of them. Well, we know one of them died, but we don't know what their response was. No response data yet. I think this was an unrelated death, but actually there were some durable responses. The second patient was unrelated death. I don't know what that death was. Some durable responses. So I'm next just appeared, and I would say it's 2039. So I'd like to say I can do a 40-minute talk, and I am going to then invite questions. So thank you very much.
Fantastic. Thank you. A lot to cover. So,
Yes.
So just really first question. You mentioned, could you share that skepticism about MRD-directed therapy? Because I mean, obviously we were very proudly sitting in that big ballroom listening to FLAIR data, and I thought, well, this is amazing. You know, this is the way to treat patients. And I just, you know, why do you think other countries finding it's difficult to, you know, I get it. It's obviously people like fixed duration, but as you showed, the first time point is 2 years, and clearly, and we've got 15 months approved, and for the vast majority of patients, obviously, you know, 15 months is just, well, it's just simply not enough. So just
I don't know. I think it's partly lack of familiarity with what we actually did. I think people thought it was more complicated than it actually is, and I think you could refine that a bit. Obviously, we didn't know exactly the right, you know, I don't think you need to necessarily do the monitoring quite in such a complicated fashion as we did. I think you could actually do the MRD just on blood if you wanted to. I think it was I I don't know exactly. I think people just quite like the idea of having a, I'm going to give you therapy for 12 months, 15 months, and not worry too much about it all. Because, and I think really thinking that treatments in CLL today are very good, and in the maybe the smaller percentage of patients are going to relapse, you've got good second line options too. Not
So
the
to
way
cover,
that you're meant to think about medicine, because we all know that we all believe that if you give treatment, you want to give your best treatment and have your best shot at it to
so
start
so
with.
if you want to obviously tailor for all, what would be the optimal length to cover those poor risk and to appease
Well,
Australians?
I think it's very difficult to think it's very difficult to balance. But I think what you can say is that 58% of patients were off treatment at 3 years in FLAIR. So almost two-thirds of patients had stopped treatment at 3 years on the MRD stopping rules. So I think you're probably looking at somewhere between 2 and 3 years you could give. And I mean, I think personally just think 15 months is not quite enough of IMV, particularly for your high risk patients. And by that I mean the genomically high risk.
Yeah. I mean, you mentioned that sort of discuss with the patient. So Lilia, could I bring you up, because I know you were on I plus V, and as a patient, would you like to be told, okay, obviously 15 months we know it's not enough, but let's say what Piers said, let's say 3 years, or MRD driven therapy?
I think personally, I would go for what works the best, particularly for first line treatments. I was 51 when I was diagnosed, and I was not just wanting another 10 years. I was greedy. I wanted longer. I didn't have I plus V as first line treatment. But I was told I would have 2 years, and I was still MRD positive at 2 years, and it was extended to 3. I think it's something that I couldn't.
You were
I think
on
that
Clarity, were you?
yes,
Yeah.
yeah. But I think there'd be a lot of different views. Some people do prefer to be told there's a fixed time frame for this, and then you're off it. Others will be much keener to have the best possible. And I think maybe it doesn't have to be one size fits all. There's some, once there's good evidence about different alternatives, there's more scope for people to choose what works for them. So some people may find a fixed term much more attractive, and they can choose to have that. But others may find, and I think a big thing with the MRD guided is whether you can do it on the blood, because I think the bone marrow will be there's not many people with CLL that enjoy having bone marrows, shall we say.
But I think that's what FLAIR showed, didn't it? That obviously the peripheral blood MRD is
So Andy Ralstrom's presentation said with two blood results looking down at 1 × 10⁵ would be the equivalent of looking at the bone marrow. I think that needs to, and that's a slight look back, I think that needs to be potentially validated more. I don't think anyone would suggest doing more than 1 bone marrow once you've on treatment. Because the schedule looks very scary, but that is all blood. And whether you need to do bone marrow at all, I think is well, we did it, so you don't know, but you probably don't need to do it.
Yeah. Nick?
Yes, thank you. It's excellent overview, Piers, going from slightly past to future, and I wanted to put on the table something to debate, which I think is very interesting, because you've mentioned endpoints of studies and the change from overall survival to PFS. And we've got Lelia here, who I know is a big defender of the time to new treatment as a relevant endpoint, much more relevant for patients. And I think it might be interesting for the people who's listening and the people who are listening to this recording to listen to the pros and cons of both the PFS and the time to new treatment, and what do we think is the best, and why was use one or the other, or whether they're complementary. So then I want to go first, maybe Piers, perhaps from the clinical side, and then.
So time to next treatment is obviously a very useful you know, in the clinic concept, but it's very difficult to define that in a clinical trial, because the starting point for a new treatment is not well defined, and unless you're going to dictate that, and I don't think you can in CLL, in my opinion. I think it's tricky. We all know in clinical practice that is what we all want to know. I mean, as a practicing clinician, is also what I'm interested. Or maybe time to next problems with your CLL, because you could argue that, I mean, there's increasing data, isn't there, now, that as the bulk of your disease goes up, you're probably getting a few more infections and things like that. So clearly that would be, so from a just a sort of practical point of view, I think the issue with it in the trial is impossible to define. There are problems with progression-free survival, of course, though, because we have to remember that some trials use a lot of scanning, and progression is defined as a small increase in a lymph node within the abdomen, which, as we know in clinical practice, again, isn't necessarily very meaningful. But not all trials do that. And so progression in trials where there's less scanning may actually appear to have a longer progression-free survival for an equivalent period of time, and actually their time to next treatment is true. I think it's just, so to me, the problem is if you want to define tightly what your endpoints are, it's just quite difficult to measure.
That's robust. And there's another, Lelia, do want to come in and speak us to, you know, the patient view on the PFS.
Yeah.
Really, it's very, very interesting to hear.
Well, it's not a very patient-friendly endpoint,
No.
because it tells you nothing about quality of life, basically. So yeah, I mean, progression on that's defined that tightly that it makes its clinical progression is much more meaningful to people, which is what the time to next treatment, I think, is trying to get at. But I think just picking Piers up on his point about should we be looking at toxicity rather than efficacy, I think probably the CLL community, I mean, if you ask almost all the surveys that I'm aware of that have been done of people with CLL, the two key things that come up are fatigue and quality of life. And, you know, it's interesting looking at all these exciting new drugs. The thing that baffled me when I first started looking into venetoclax, because the study I was in was a phase 2, was all the, it rammed home that basically new drugs are tested. It's what's the maximum tolerated rather than the minimum effective. And if we could get at the minimum effective dose of all these drugs, I think we might, you know, that would be much more patient friendly.
And I think when you've got such good efficacy with the drugs we've got, I think that's probably something we could look at, or certainly for an awful lot of patients with CLL, because the group that have got that really genomically nasty to treat disease are probably relatively small in terms of the whole CLL population. And I do think this is one of the problems with the MRD-directed therapy for, let's say, in flare for CLL. I mean, I didn't go into it, but it's slightly strange that patients who've got, well, it's not strange if you think about the biology, but for patients who've got what we consider benign disease, which is the mutated IGHV, they do not achieve MRD negativity to such a great extent as the unmutated ones. And so there is a danger using just an MRD-directed strategy. You would definitely be effectively over-treating a group of patients. Now, some people might say that's fine, but if you're one of those patients and gets a very nasty side effect on that combination and you actually didn't need it, I think it's a real problem. And how many patients is it acceptable to do that to? Probably not very many, if any.
Yeah.
So the purists say, I want to get all my really horrible genomically complex CLL really well treated. But actually, the reality is you probably knew about those patients to start with if you tested them. And they're not actually, you know, they're not that many patients like that. Actually, so many of them. They just, as Lelia says, once stop having, wants a good quality of life, doesn't want to feel as tired, needs their disease to go down to a level which is manageable, which gives them all of that things.
I mean, that's another.
Go ahead, Lilia. Sorry.
Sorry, just another factor in the fixed term is that if you take time, you might need to adjust the dose. If you build up the dose more slowly, I certainly found that helped in managing the side effects. And if you've got a fixed term, then that eats into your term, presumably. So if you've got 15 months and you take longer to get to the maximum dose, that's a more difficult concept.
Yes, I think that is a good point. And I mean, I'll be honest. When I give when you give sort of venetoclax or obinutuzumab, I mean, you quite often delay starting with, because you've got cytopenias or whatever, waiting, okay, week or two, but you need to make sure that you give the full length. You sort of need to add it on at the end. So
Yeah.
it should be, this is the amount of drug that you're going to need.
And begin on the point of MRD and something you perhaps didn't go too much into, but you've managed to mention a few doublets of trials that are testing BTK inhibitors and BCL2 inhibitors, and it's perhaps a good time to discuss what we think about the triplets and why they've been investigating several trials that we know the results of, perhaps some others that are waiting to read out, and what's your interpretation of those triplets and what the impact are they having on the depth of MRD, and do we really think they're going to change the game or not? It's interesting to discuss that. I have my personal opinion. I think they probably are not adding much, but interesting to hear other people's thoughts.
Sorry, was that triplet therapy? So by that you mean BTKI, BCL2 inhibitor, and
Antibody.
and antibodies. So the data we've probably got the most on, I mean, there's lots of studies out there, but the CLL13 study had an arm of that, and certainly when that first read out, it was suggested that that triplet had no additional benefit to just having BTKI being ibrutinib and no ibrutinib being venetoclax or obinutuzumab. So, and I think the worry was that caused too much toxicity. I don't know if it was covered, but there was a suggestion that those patients with unmutated disease might be doing a very, very little bit better with that, and maybe we will see a slight benefit from that. I think my personal view about triplets is I think we need to really think about what is it the very, very high risk genomic patients who might benefit from that and really target it. I think for most patients, triplets are unnecessary.
Talking about MRD, how far do you think we are from using MRD as an endpoint? It would save huge amount of money from following patients to 6-year overall survival, progression-free survival, rather than just having that readout of MRD. Do you think we're there yet?
Well, the regulators tell us we're not. I think one of the roles we should have in the UK community is to say that we actually did achieve this. We had 100 centres in Flare, and we were able to deliver a study using centralized MRD, or it could be, doesn't have to be one place only. So I think it's doable, and I think we should say that to regulators that it is possible. So the argument that it's not achievable, I don't think is true. I think there are other countries it's not well set up. That's certainly true in the US. And the worry is it's not standardized if it's done by flow cytometry. There are more genomic platforms which may or may be easier to standardize. They're very expensive, and B, there's no actual standardized readout between them. So I think it's a problem. So I suspect we're still some way away. If you were at the IWCLL meeting, there was really quite a profound disagreement amongst leaders in the field of CLL about the role of MRD in CLL. And so I think if as treating clinicians we can't come up with a agreement about it, it's going to be very difficult to persuade everybody else. So
yeah, as you said, that won't be very good outcome for any BTKI type of
Yeah.
therapy, and yet we get very good remissions. So what does it really, which outcome it matters?
Well, I think we need to apply MRD to only where it's very meaningful, and it's clearly not that meaningful for patients on BTKI monotherapy. It doesn't.
Yeah. And just to pick, because we're running out of time, bispecifics. Do you think why? I mean, usually with CLL, we're leading the way of the treatment. Do you think it's because there is too much tumor and being scared of sort of side effects of it? You know, why we were so late joining the party?
Well, I don't think we're too late joining the party, because I'm not sure they're necessarily going to have a massive role in CLL. I think when you look at the data, it's quite disappointing, and we've got very, very effective drugs elsewhere. They might have a small role, but I don't, unlike, when we've got drugs like we have today, just because everybody else is using them, they're not without problems, bispecifics. They do cause infection problem. I mean, it's interesting, the data that's coming out on the long-term infectious complications of cellular therapies that will apply to bispecifics as well. No one can decide whether to give them continuously or fixed duration. And there is a profound T-cell dysfunction in CLL. So I think it is partly bulk of, there are multiple reasons for that. So I don't think we should say, oh, we've missed out.
Okay.
Yeah.
Well, I remember them sort of when we were talking about trials, sort of using as a consolidation, but obviously that's,
Well, no, I'm not saying we shouldn't necessarily try that, but I mean, I look at the data and I wonder. I mean, if I was a patient, I certainly wouldn't be reaching for bispecific as my next option. I mean,
Lilia, what do you think?
but
What's your thoughts on bispecific?
I think probably the honest answer is I don't have any. I don't know enough about them to say anything very much, Renata.
For all the attendees, I've got one more question to Piers, but this is if you're leaving our meeting, we would really appreciate exit polls so we can continue to improve on this basic course, and obviously we would love to bring it again next year. So Piers, last question. Do you think we can pull off a study like FLAIR again? I mean, obviously, I know what's my research department looks like. They look like they're assessing every clinical trial, how much money that clinical trial can bring and support our research department. So with any sort of academically driven studies where obviously they might be actually deficit rather than bringing income to the hospital. Do you think?
I think there are lots of reasons, but I think we just need to look at where we are with CLL today compared to where we were when FLAIR opened. We were still using chemoimmunotherapy in the main and had very little access to agents which showed extraordinary responses in the disease. So I think there was an unmet clinical need when FLAIR started, which I'm not saying there's no clinical need for trials at all now, but I think that it will be difficult to get quite so many centres on board with quite so many patients again, simply because the field has progressed massively. That's not to say we shouldn't be doing clinical trials in CLL. I think probably the one size fits all almost trial is probably in CLL may not be so apparent. So I think we need to look at a range of different studies, and as a interested researcher and trying to also do the best thing for my patients, I think if there's an appropriate trial for those patients to go on, we should still encourage that.
And thank you for that. And super quick question: are there any free of charge medication? Obviously, we used to have program of pirtobrutinib.
I'm not really aware of any free programs at the moment.
Okay. We banged on at 9 p.m. So thank you all. Thank you, Piers, for a really good update. Thank you, Nick, for stepping in and helping with co-chair. And thank you, Lilia, for being patient rep and bringing this really valuable patient insight to our discussions. And thank you all for joining this evening. And hopefully we'll see you next year.
Thank
Goodbye.
you. Thank you, Renata.
Nice
Thank you,
evening.
CLL SA team as well.